Okay, so let's talk about congenital disease. Okay, say, Dan, what do you think of this case?
T2 sagittal, 54-year-old male with back pain. T2 sagittal showing me some disc desiccation at the L5, 4-5 level.
Okay.
There's a box up there which, oh, so there's like some kind of like T2 hypertensive signal anterior to the lumbar spine there, L2.
Okay, the axial images.
Yeah, so some kind of cystic possible.
Here's another view of it.
Well, whatever, it's like some kind of like pseudocyst dealing with the aorta there.
Yeah, it's not really a cyst,
Oh.
but that's okay. That's just visualization of the Cisterna chyli. So if you see that, remember the structure that we all forgot about since medical school, right? Elior.
46-year-old, low back pain extending into the left leg. Yeah, the spinal canal, kind of that right paracentral region looks odd. I think that the fat is getting pushed to the midline, and there's maybe a.
So is this odd or is this odd?
I thought the right looked odd, but
okay,
it's on the left, so.
Let's look on the left here. Okay, what might this be?
I mean, if that's not the nerve, then.
Sure, starting up high. So this nerve root's getting out normally, let me put it that way. So what could be happening over here? Here's the next cut.
Okay, I mean, if that.
So there's a nerve root out there on the right side, but this is all different on the left.
You're right.
And there's the next cut. So here the nerve root is kind of delayed, or it's inferiorly placed in getting out more inferiorly than on the right side.
Mm-hmm.
So if we go to the next cut, notice what it looks like here. It's like there are two nerve roots here, but only one there, and then something else coming off the off the thecal sac here.
Mm-hmm.
Bringing the asymmetry. So this is normal on this side. This is abnormal on this side. Any ideas? It's not rare. This used to be something that's kind of important to mention if somebody's thinking about surgery. And then here we can see asymmetry. So this is called a conjoined nerve root. So that's when two of the nerve roots are kind of fused together on one side, and then typically the upper one is dragged down a little bit, the lower one is dragged up a bit, and they're a little bit late getting out. Mm-hmm. And it can be a problem if the surgeon doesn't know about it, because there's a little increased risk of damaging one of the nerve roots if they're not aware of conjoined nerve root on one side. And it's a little bit controversial, but some people feel that it can actually cause symptoms. Okay. Robert.
All right, so we have a 69-year-old with increasing chronic low back pain. I guess the distal spinal cord looks a little irregular and thickened.
What's this?
Is that an adhesion there, maybe?
Okay. So let's go through the axials here. There's an axial.
Okay.
There's the axial. There's an axial. Now we're at this level.
Huh. Okay.
And there's an axial.
Yeah.
And there's an axial. Now we're up here.
Gotcha. So there's a syrinx in, yeah. There's a syrinx, and then it looks like there's two spinal cords there for a short segment.
So what does that mean? And then they're back to a
spina. This is spina bifida.
Well, this patient has spina bifida, but what we're looking there, the cord is tethered, which means that the conus is low down. But this is diastematomyelia. And then patient did have a syrinx, but the primary thing here is the diastematomyelia. What this is a fibrous band that's going through the center of the cord. Oops. Right here, it's this thing. And then here, this is at the level where we have two, really like the cord is brought way far down. And then we actually have diastematomyelia with the cord is divided into two. And there could be a fibrous or even a bony separation between the two components of the cord. And there we can see the two components together. And you shouldn't even have cord at this level, but this is all congenital. And it's pulled down. Okay. All right. And again, if you think somebody's thinking about surgery, it's very important to know about diastematomyelia because it could have a traction on neurostructures and damage if the surgeon's not aware of the finding. Okay, Tayson.
All right, 48-year-old female. I think the spinal cord seems a little low lying.
Yeah, looks like it's coming all the way down here. And
Yeah.
disc disease down there. Yeah. So this is another tethered cord. And the end of the conus is too far down. And it lacks of ascent. John, do you want to talk to anything about a tethered cord? You used to do a lot of surgery in kids with congenital disease.
I never did back surgery on children.
Oh, you didn't? Okay. All right. Just
We had a special clinic for that.
okay. Okay. Dan.
58-year-old female with sacral mass at birth with pain. Past medical history of left nephrectomy due to renal TB. Like that's blue. BP, pelvic radiograph. Not really seeing much. I guess there's like, what is that? My lord. What do we fit in with that?
What?
I feel like I've seen that before in a book, but I can't remember what that is. Laterals.
Yes. Okay. There's the MR.
So there's like agenesis of the sacrum. Looks like like a
And what do you think this is?
yeah. I thought it's not a foregut duplication cyst. It could just be some type of
Well,
granulation tissue.
These are T1. That's
Yeah.
T2 weighted image. This is a T1 weighted image.
Yeah.
So what kind of tissue is this? Now you see the defect posteriorly here.
Just like it's not like
It's fat, right?
yeah.
Okay. So what do you think this might be?
Oh, like it's called lumbar like lipomatosis. No.
Okay, so this is spina bifida with a lipomyelomeningocele. And then you've got a tethered cord here, which is producing symptoms. So this is a big lipomyelomeningocele. So I think the anterior posterior be associated with sacral agenesis, and they're commonly associated with tethered cords. Okay. All righty. Normal or abnormal?
Abnormal babies with fusion of lumbosacral region.
Okay. So imaging is important here. The biggest thing to determine this situation is do they share nerves and nerve roots and cord, or do they have separate neural structures? So what do you think here?
Okay, so the radiograph, the baby on the, on the right, radiology right, has no, I don't see a sacrum.
So you're talking about over here?
Yes. Yes.
Okay, so it looks like there's some of the sacrum missing here compared to the other child. Good. All right, then we go to the CT.
Okay, so on the right is that, I think was that baby with
Your right or their right?
uh,
Why don't we call this the right and this the left for now?
okay. So
So basically here's a sacrum and we are missing posterior elements here.
yes.
Okay. So they have a spina bifida here. And if we go to the reconstructed images here, you can see the sacral, part of the sacral agenesis here, both on both sides, and the fusion here of the soft tissues. Yeah, in the spina bifida. And then that's the 3D imaging. And then if we do an MR examination, what are you seeing here?
Yeah, again, missing the posterior elements, and there's looks like communication between the spinal canals at that level.
And so what you're seeing is the bottom terminality comes down here, and at this level, there's kind of sharing of the lower neurologic elements. But at least down to the phalanx terminology, you're seeing separate cords and separate nerve roots coming off the spine. And then here we can see the T2 weighted images, again showing you just sharing the phalanx terminal there. And they were able to be successfully separated. Okay. All righty. Robert.
All right. Here we're looking at the L spine and in the neuroforamen. I think it's at L1. There's a cystic structure right on T2 imaging and dark on the T1 imaging.
And there's a post-contrast.
And it does not look like it enhances. So I think it's just a simple cyst.
Okay. Yeah, so that's a nerve root cyst, seen quite commonly. Usually we kind of describe them, but usually they're pretty much ignored, not thought to be a cause of symptoms. Okay, let me just see. Yeah, there's post-GAD, root cyst, and here a more nerve root cyst coming out of the neuroforamen. Often, if they're congenital, you'll get widening of the neuroforamen there. If they're more later acquired, the foramina are more symmetric, like we're seeing here. Yeah. So I usually just describe them in some detail in the body of the report, and then if they're large, I'll put them in the impression. But if they're pretty subtle, I usually only describe them in the report. Okay, Tayson.
All right. So, yeah, the sagittal images looks like there's a epidural cyst there.
Okay. Yeah. So this is it's in the
That's a mass effect from posterior to the spinal cord.
You can often get posterior, and these are arachnoid cysts. Again, most of them are not symptomatic. Let's see, Dan, what do you think of this case?
Okay, so yeah, T2. Just like cystic formation, agenesis of the sacrum again.
Well, in this case, we can see that the sacrum is there. It's just that you've got a lot of expansion of the neural canal here where this cyst is. And if you look here, here's the T1 and here's the T1 fat set post. It's actually cystic. So if you go to CT scan, this is what it looks like. So what do you think this is?
I'm not sure exactly what this would
Okay,
be.
so this is another arachnoid cyst. And these are probably congenital. They can expand the neural canal here. If they expand like this, they may be symptomatic, but that's a little bit controversial. You can usually see the nerve roots going through these, maybe, or displaced around them. And I think most of these are not symptomatic. This is a prominent one.
75-year-old male with back pain. Yeah, here we see some cysts, lower lumbar spine. Could they be nerve root cysts? Yeah, it looks like there's degenerative change of the facet joints.
Yeah.
There's some fusion as well.
So they actually, I think, operated on this particular case, and they thought these were dorsal dural diverticula, and thought there was some adhesive arachnoiditis in with this, but these are probably dural or arachnoid cysts, which are there, probably congenital, but maybe for a long period of time, enough to actually produce erosive changes involving the lamina. Okay. Robert?
All right. Let's see. Here we're looking at this, I think the sacrum. It looks like there's a cystic structure kind of where at the bottom of the field of view. Yeah, where the...
At least it's low in signal on the T1, lower than fat anyway.
Mm-hmm.
You know, obviously abnormality of the coccyx down here.
Mm-hmm.
And if we do oblique axial images, now we have a T2, which does look like it's now fluid containing.
Yeah.
Biggest problem with those is that they don't take enough tissue out.
Uh-huh. Yeah. So this was just a
Usually you'll find hair in there and other entities. It's not an uncommon problem,
Yeah.
and not infrequently you have to go back and redo the procedure if you're not very careful with the first one.
Okay.
But it's a miserable condition to have. Usually these people are quite hairy also.
Okay. All right. Payson?
All right. Do we have some sort of transitional anatomy here? Yeah, like left hemisacralization.
Right. Yeah. This produces a syndrome that I don't know why I have this here. This is really not where I want it. This produces a syndrome that we're going to talk about in more detail later. The problem with this is that it changes the stress characteristics through the lower spine and makes it asymmetric. It tends to be it's at L5, S1, where the lateral process of L5 actually articulates with the sacrum. It can be on one side or both sides. On one side, it tends to produce stresses in the spine, which tend to affect the L4-5 disc, causing early degenerative disease of the L4-5 disc. In my experience, this is the most commonly missed significant congenital anomaly in the lumbar spine. And we're going to come back to this later.
Okay.
Okay.
47-year-old male with long history of increasing back pain. AP radiograph, you see like a bit of a scoliotic curve, dextral curvature.
Okay.
Looking down,
If we blow up this thing here,
Yeah.
blow it up, looks like that.
so it looks like there's prominence at
I
the
guess we're going to discuss this now, maybe.
L5. That's one.
Yeah, if you see over here,
Yeah.
see this?
So yeah, it looks like another.
Looks like another articulation between the lateral process and the sacrum of L5 and the sacrum. Here's typically what the MR scan looks like. You'll get degenerative disease at 4-5. 5-1 is kind of mild disease here on the sagittal images. And if we go to the axial and coronal images, what do you see?
You see that pseudo or that articulation.
Right, over here.
So we should just like say
And typical for, so this is on 7/27/07. This was not described in the radiology report. They just said some degenerative disease at 4-5 and 5-1. The patient came back 2 years later with increasing pain, and this is what it looked like 2 years later. So here's 4-5 at this time. Here's 4-5 as it was before. So it's progressed over 2 years to more degenerative disease. Okay. And, this is producing abnormal positioning of the spine, and we have overlap between the 4 and 5 spinous processes. This can also produce pain dorsally. Go to the CT scan, we can see that arthrosis over the articulation on the left in this particular patient. Here's a reconstructed coronals, and we can see the abnormal articulation between the lateral process of L5 and the sacrum, and the severe degenerative disease at the L4-5 level. So I think this should be picked up very early, and they can do surgery on this to try to protect the L4-5 disc. But and you can just see these changes if you go to 3D as well. And so does anybody know the name of this syndrome?
Bertolotti.
Great. And so this is Bertolotti syndrome. So here, like everything, like so many things, there are classifications of Bertolotti syndrome. This is the Castelvi types. You can have a dysplastic transverse process with too large of a height. You can have a transverse process pseudoarthrosis with the sacrum. You can have an actual fusion with the sacrum on one side, or you can have a fusion on one side and an articulation on the other side. All of these can produce abnormal positioning of the lumbar sacral junction during motion of the spine and produce symptoms that tend to predominantly affect the L4-5 disc. And again, it's very commonly, and the 2 and the 4 tend to be the most symptomatic of the 2. And my experience, this is very commonly missed by radiologists. Okay.
45-year-old chronic low back pain. Yeah, it looks like maybe on the AP radiograph, you said fusion, the transverse L5 with the
Yeah,
bilaterally.
yeah. So, and it's nice to have plain films on these so you can count down 1, 2, 3, 4 vertebral bodies here. So this would be 5, but we can see on both sides this vertebral body is articulating with the sacral elements here. So is this 4 vertebral bodies, or is it 5 L4 vertebral bodies and an abnormal 5S1? Well, we can see on the MR scan is we have the typical degenerative disease of 4-5 with a disc protrusion posteriorly. 5-1 is relatively normally maintained here in this patient because it's a stable area. A little hard to see here, but you can see the articulations on both sides of what could be the L5 vertebral body. So in situations like this, I think you need to, so this is one that's bilateral disease, Bertolotti syndrome. And you just kind of need to decide how you want to number things and then make it very clear in your report there's a congenital anomaly. And for the purpose of your report, you're going to label the spine as follows and make it clear. So you could say that this is the L5 is bilaterally articulates with the sacrum, or you can say there are L4 vertebral bodies, and the S1-2 level is congenitally abnormal. But just make it clear each way what it is. And then here just some kind of descriptions of another classification system where you can evaluate whether you have one side or both sides and the kind of fusion. But again, I would just describe what you see. The most important thing is to look for it because Bertolotti syndrome is not rare. And so be sure and look for it and then just describe it. Okay, Robert.
All right. Here, looking at the spinous process.
Actually, let's stop here. This is a good place to stop. We'll start with this case tomorrow. Okay?
Okay.
Thanks, everyone.